Thank you so much, Dr. K. Agarwal and eMedi News for this opportunity. I'll try to make my presentation very crisp because I realize it is. Now, my basic question is 5, which I will try to answer, is I think you disconnected. Can you just connect that? What I try to answer is, why do you need liver transplant? When do you need a liver transplant? Who can donate liver? What are the challenges that are involved in liver transplants? And what is the outcome of liver transplant with our experience? You need a liver transplant when the liver fails, either due to a chronic liver disease or due to acute liver failure. Besides that, sometimes there are some metabolic errors where, like, not only the liver, the enzyme is deficient in the liver, but the effect is on the other parts. It could be brain, like urea cycle organic acid defects. It could be the kidney, hyperoxaluria. It could be the heart, familial hypercholesteremia. So here, you change the liver because the effect is seen on the other part of the body. Besides that, you could have some tumors, cancers, etc., where you need to change the liver. In the etiology, since our team in India, we've done around 945 liver transplants, of which 87 have been pediatric and the rest have been adults, of which 107 were acute liver failure. So I had to see the etiology in adults. There's been a lot of hepatitis C, B, and alcoholic liver disease, more common in adults. If I have to see the etiology in children, in the acute liver failure, it is quite a big chunk that we see this, and the rest chronic liver disease in children is mostly biliary atresia and other cholestatic liver disorders that you see. And in the hepatitis, we usually have hepatitis. Only one child we did with hepatitis B. Otherwise, they present to you in adults. And metabolic like Wilson's, anemia, glycogen storage disease. Second question, when do you need? So the first thing is, when you think about a liver disease, please refer early. It is very well said in 1983 and it still holds. It should be performed late enough in the disease to give the patient opportunity for spontaneous stabilization, but early enough to give the surgical process a fair chance of success. When the patient is very bad preoperatively, the success rate will be low. So that is very important message, that the success depends on the status of the patient for the transplant. How do you select a patient? It is the MELD score or the PEL. PEL is for the pediatric, MELD for the adult, the score 15 or more, and a CTP score which we call the Child-Pugh score, which every physician should know. The Child-Pugh score should be 9 or more. That means child B or child C liver disease. That's when you need it. Third question, where do you get the liver from? You get the liver either from a cadaver. A brain dead person can give his or her liver to someone else. Unfortunately, in India, cadaveric transplant did not take the speed. So we've been doing living related liver transplants where a kith and kin donates a part of his or her liver to the patient. How can you do that? Because liver is the only organ which regenerates. It has been kind to give you one liver, but it is 7% extra than what you need. Therefore, a healthy person can eat a part of his liver up to 60-70% and yet can regenerate the liver back. That's how you do it. Do you need etching? No. You need blood group compatibility? Yes. Who can donate? It is the family member between 18 to 55 years who should suffering from hepatitis B, C, HIV, etc. and should not have a very fatty liver to donate. How much can you donate is, in an adult usually you need the right lobe, in a child you need the left lobe, in a small child you can just use the left lateral part and then give it a very like 3-4 kgs baby. We reduce it and use mono segment because we have 8 segments in the liver. So before taking the liver from a donor, we do a lot of CT scan, angiography and volume because the patient who gives is God for us. So you have to test him from head to toe. Nearly 60,000 rupees investigations are done on the donor, wherein you assess what is the anatomy of the vessels and you decide how much liver to be taken. This is how you calculate the volumes into the vessels. You do MRCP to look into the ducts. This is all in the donor, I'm saying. After doing that, how much liver do you need? On an average, you need 0.7 to 0.8%. A 10 kg baby, 100 grams. 50 kg man, 500. So that's how you need a part of the liver. How much liver to be left behind? You should leave at least one person can donate 70%. You should leave back 30 to 35% for that. Next question. What are the challenges pre-transplant? Remember, this slide shows you that in a malnourished patient, the survival is poor, hospitalization is more, ICU stay is more, cost is more. So the key message, nutrition pre-transplant is very important for the success, where we can work nutritionally, and that is why I said we need to refer early to that. We give them all the vaccines pre-transplant, post-transplant we don't like to use live vaccine. Not only an adult, even a child, we try to explain them with play therapy and psychology what we are going to do pre-transplant, because the mental preparation of a patient, whether a child or an adult, is very important, because that's how you will contribute. What are the challenges in the surgery? In one slide, I'm depicting a lot of things that are going around. The cycle, the anesthesia, the fluid status, the goals, the blood coagulation, the machines. So a huge thing is going on in the surgery while we decide to look into that. Sometimes we are not able to close the abdomen, so in small children we even put a mesh after putting the liver and gradually remove that mesh. Recently you must have read in the newspaper about our first robotic surgery which we did in liver transplant. Our team was the first one to do it in a donor, and that was 2 months back. And how does a robotic surgery affect? Because there is a lot of the tremors and the surgeon's fatigue is less and the mobility is more. So that's how these robots are nowadays being used, which is in our center, in using for the donor surgery to cut down this. Now, what are the challenges post-transplant? Having talked to you when you need it, where do you get the liver? What are the challenges pre-transplant and surgery? Now I address the second last question, the post-transplant. You need to monitor the patient in an excellent ICU where a lot of things are going on with the patient and thing. And in the ICU, you talk about the ventilator, you should ensure that there is not much infections. You're worried about the vessels blocked. You have to look into the physiotherapy and the renal and the fluid status. A lot of things are going on simultaneously to look for this surgery. Now, do you need immunosuppression lifelong? Yes, most. The data recently is suggesting 25% might outgrow the need of transplant 10 years down the line. So this is future to see that yes, genetics are now saying that maybe we don't need, but for the time being, let us assume in most we need. What immunosuppression? Usually tacrolimus is used liver transplant along with mycophenolate to do. Coming to the last question, what is our team's experience? We've done 945 liver transplants with 87 pediatrics, of which 107 by acute liver failure. The youngest was 5, the oldest was 78 years. He's now 2 years post-transplant and he works still 7 hours a day. And we have done a lot of babies, 30 who have been less than 10 kgs. The results have been one of the best in the world, with 93% at our center, which is equilibrated into the top few centers. Overall survival in children have been better than in adults. They are around 90%. The quality of life is supposed to be. The 1-year survival, as I said, better than adults. It's 66 versus 93 in adults. This was what my chairperson was addressing to. Recently, on 8th January, you must have read in the newspaper, we did the world's first chain of transplants. What do I mean by that? I had a young girl called Tejashri. She was B positive and suffering from maple syrup urine disease, where the enzyme to digest proteins is deficient. This enzyme is normally present 6% in muscle and just 10% in liver. By giving her even 10%, she can survive, and otherwise she needs restricted diet throughout life. But I can't use the father's liver because he is going to be a carrier. He will have only 5% of the enzyme, which is not going to be adequate. So another child I had, Ansa, a doctor's child, she was O, both mother and father were B. So what we did was, the father of Ansa donated a small left lateral part to Tejashri, and similarly, Tejashri's father donated a part of his liver to Ansa. This is called swap transplant. But we have done this earlier too. What was so unique? The unique was, since I said in Tejashri she had MSUD, her liver was absolutely normal except one enzyme which was deficient. And this child was suffering from biliary atresia. He would have that enzyme in his muscles. So we gave Tejashri's liver, which we took out, the bad liver from the body. It was not thrown out. It was instead given to another child who could use it because he had enzyme in his muscle, and this is called domino transplant. So simultaneously, 6 theaters were being used for 5 of these patients, and one, the liver which was removed from this, we had to do table surgery before doing it. So all these patients were interlinked, and all the surgeries had to be done simultaneously, and that's what we created that record which the kind talked about. Before this, done the first domino transplant in the world. That was what this year was again suffering from MSUD. We had given this liver to another girl suffering from liver cancer. So that was the first thing, and we broke our own record. And we did the first factor 7 deficiency in the world. So now we have told the world that by replacing the liver in factor 7 deficiency, you can give a new life to them. And of course, combined liver kidneys can be for swap transplants. And besides that, we've achieved first in this. In an adult, what was interesting was 2 children had to donate, one right and left, so that they could give him a complete liver to salvage. And it is the team who looks into the success of surgery. At Medanta, we have a 150-bedded state-of-the-art facility with dedicated liver ICUs, pediatric center, etc. And it is worth the effort to give smile to all the patients. Thank you for your attention.